Jennifer McDougall, and I'm pleased to moderate this next session. It will include 4 presentations that will provide an overview of what is known about effective interventions in the early childhood years. And after the presentations, I will moderate a discussion with this panel. So I would like to first reintroduce Dr. Elsie Taveras from Massachusetts General Hospital, who will provide an overview about what is known about effective interventions in pregnancy and birth to 2 years of age. Please again welcome Dr. Taveras.
Thank you. Thank you all for tolerating me for 2 talks. Let's see if I could get my slides up. So this morning, I talked a little bit about the epidemiology work that I've done and that so many of us have done. And it's really exciting to now be able to transition to what I've been kind of stung by, which is trying to translate that, the evidence that we know already exists to interventions. And so what I'm going to talk about very briefly today, because of the lack of effective interventions, is about what we know works, what doesn't work in the first 1,000 days, which you heard a little bit about earlier today. And then we're going to have a series of talks that will expand on those to 2 to 5-year-olds and in different settings. And so what I'm really focusing in on, which is a little bit different from the speakers that'll follow, is what we've been hearing about the first 1,000 days, where Pepe already mentioned, is this period from maybe preconception or conception through 2 years of age when interventions can help shape a child's future. And so I want to tell you a little bit about a systematic review that we've done of interventions implemented in those first 1,000 days to prevent childhood overweight or obesity. Talk a little bit about the distribution of the existing interventions, what levels they've intervened on, the settings where they've intervened, and summarize some research gaps. And then end with a discussion of a potential conceptual framework if we're really trying to think about both prevention and reduction of health disparities in those first 1,000 days. So over the course of the last year, we were commissioned by the Robert Wood Johnson Foundation to conduct a systematic review, and actually the first author is here in the audience, Tiffany Blake Lamb, who's an OBGYN at Mass General, and has really led this systematic review where we've looked at existing interventions that have been implemented during the first 1,000 days that included as an outcome prevention of childhood overweight or obesity. So just to clarify, we didn't include in these interventions that we reviewed studies that only looked at maternal outcomes. In order to be included in this review, there needed to be a child BMI or anthropometric outcome in the infant or the child. And so we included and looked at English language studies where there was an intervention and a control group, where the intervention was implemented from conception to 2 years of age, and where the study outcome included a measure of child overweight or obesity collected between the ages of 6 months and 18 years. We excluded those that only looked at birth weight as an outcome. And from that review, we identified 34 completed studies from 26 unique interventions, and only about a third were found to be effective in improving childhood weight status. And I'll summarize what we found in those studies. I should also mention that in addition to looking at completed interventions, we looked and searched in clinical trials for those that are ongoing, and there were some really striking differences. I think of the completed interventions, they're being conducted at a variety of different settings: clinic, home, community, or a combination. There are still a number of studies that are doing and testing trials of supplementation, so more of on the biological intervention, and a complete lack of systems-level interventions in those studies that have already been conducted. And then when you look at some ongoing interventions based on the data that's available within clinical trials, we've seen a huge growth in the number of interventions that are clinically based. And one of the interventions, or one of the talks that follows, is by Ian Paul, who's going to talk about the merits of clinical interventions, particularly for infancy. But it's really interesting to see that difference. And what looks like an emergence of more systems-level interventions where we're intervening upstream rather than intervening individual-level behaviors in families. So the next few slides are going to tell you a little bit about what we found works from the literature. We found that interventions that worked demonstrated an effect by primarily focusing on individual or family-level behavior changes, with the caveat that most of the interventions that are published are really focused on the individual or family level. Interventions in homes, clinical settings, or group sessions held in community-based settings in those first 1,000 days were equally effective. And you'll hear a little bit later in Kirsten's talk how that changes from 2 to 5 years of age, where there are some clear differences in the setting in which interventions are occurring. At least in pregnancy and infancy, it seems like the setting doesn't make a big difference in the interventions that are more effective. So a few examples of studies that have worked and a little bit more information about those studies. The first one is Healthy Beginnings, a study by Wen et al. That published earlier in 2012 their results looking at 2-year outcomes, and then this year, more recently, published their longer-term outcomes at age 5. So Healthy Beginnings worked with about 667 first-time mothers and their infants who were socially and economically disadvantaged in Australia. They conducted 8 home visits conducted by community nurses, and each lasting about 1 to 2 hours. One of those visits occurred prenatally. 7 visits occurred in the first 2 years of life. And the targets of Healthy Beginnings was breastfeeding and infant feeding, activity, really focusing in on family-level changes to nutrition and physical activity. And at 2 years of age, Healthy Beginnings saw a BMI that was 0.29 kilograms per meter squared lower in their intervention group compared to controls. But by 5 years of age, there was no sustained effect on BMI and no effects of the intervention on dietary behaviors or the other health behaviors that they intervened on. I should mention, as I said, the intervention ended at 24 months. And you'll notice a trend in some of the interventions that I'm going to mention that worked in the short term and potentially weren't sustained in the long term, because it makes a difference in how we plan ahead some of our own intervention activities. Nourish was one of the other interventions that worked. Nourish is a RCT that recruited 698 first-time mothers and their healthy term infants. And they conducted an intervention that also ended around 15 months of age, where they held 2 3-month group education modules that were really focused on skills development of families or parents. They focused on parenting practices that mediated children's early feeding experiences and really focused in on protective complementary feeding practices. At 13 to 15 months of age, when the intervention ended, they did see improvements, and they saw a lower body mass index Z-score in the intervention group compared to control. But by 2 and 5 years of age, they still continued to see an increased use of protective feeding practices, but no difference in BMI Z-score or prevalence of overweight or obesity. So do we define that as working? I think so, with the caveat that I'll mention later, which is maybe we need to think about this in a life course or as a life course approach, and as some intervention activities end, others need to be picked up to sustain these effects. Slim Time, which you've heard already quite a bit about, was a 2x2 intervention design with 160 mother-infant dyads led by Ian and Leanne. The 2 groups, or the 4 groups, received either a soothe and sleep or sleep intervention, where mothers were taught to use alternate soothing strategies in response to fussiness, this idea that not all crying should be dealt with by feeding. And also focusing in on the introduction of solids. And at 12 months, Slim Time achieved a lower weight for length percentage in the group who received both interventions compared to the other 3 groups. And that intervention ended at 1 year. And then finally, STRIP, which is probably the most well-known intervention of infant feeding and child feeding practices over the course of 10 years. So STRIP was a randomized controlled trial where they randomized about 1,000 infants at 7 months of age to intervention and control. The intervention group received individualized dietary and lifestyle counseling at clinic visits every 1 to 3 months until 2 years, 2 times per year until they turned 7, and then yearly until they were 10 years of age. They focused quite a bit on diet and physical activity and found that among girls, but not boys, at their outcome period at 10 years, 10.2% of intervention and 18.8% of control girls were overweight, and no difference in overweight among boys. What doesn't work? We'll start there. Protein-enriched formulas actually increased the risk of childhood obesity in the papers that we reviewed. None of the interventions focusing only on pregnancy resulted in improved childhood obesity outcomes among those that actually measured childhood obesity outcomes, which were very few. Quite a number of lessons learned from the review and of the effective interventions. I think first and foremost, which we've seen in a bunch of the interventions where they've had short-term success, but they're not sustained when you look at outcomes 3 or 5 years later, is that obesity prevention programs need to be continued or maintained during the early childhood years and beyond. It's no wonder that we see the intervention effects when we're actually intervening. But it's also important to think of what might be some risk-reducing interventions that are conducted over time, potentially not through an intensive intervention, but that can be picked up in the settings where children spend their time. So I'm not suggesting a 10 or 20-year intervention from birth to, when we send children off to college, hopefully. But this idea that, it's no wonder that, we see interventions that tend to lose their effect as children get older or as we stop intervening. We have to think creatively about what are some other risk-reducing activities that could be sustained over time. And also, throughout the studies, the importance of and the particularly in environmental context and social context in both the planning and sustainability of some of the interventions. The most effective interventions were those that really did focus on the family and that attempted to change the environment. So quite a number of things are missing from the existing literature. None of the studies that we reviewed or that were effective intervened on maternal pre-pregnancy BMI or prenatal tobacco exposure. And I would say, we really need to try to find a way to reach women who are intending to become pregnant. It's difficult for the reasons that we heard earlier, that so many pregnancies are unplanned, but we have a lot of opportunities to intervene in women of conception age or who are in that age group where they are intending to become pregnant. Many infant feeding interventions focus solely on breastfeeding, and it's an opportunity, but a huge gap in the literature to try to really focus on women who, for some reason, non-judgmental, have chosen to not breastfeed. And I think we do a disservice to those women who have chosen to not breastfeed, to not be able to counsel them on responsiveness or even how they can prevent obesity among their children who are being bottle or formula fed. Very few interventions assist women who are formula feeding. No interventions focused on reducing the introduction of sugar-sweetened beverages in that 0 to 2-year-old period. Again, a huge opportunity. Systems-level interventions and those using community-based settings are completely underrepresented. And it's good to see that there are a number of those in those trials that are still ongoing and not yet published. But again, quite a number or quite a lack of evidence in the literature of effectiveness. And few interventions trying to impact the social context or upstream influences on obesity. There were very few interventions that took advantage of settings where children already interface with federal systems, WIC, for example, or that took advantage of potential government policies such as food subsidies and private sector practices such as fast food marketing. I want to end by mentioning another opportunity that I think we've often missed, and particularly I'm starting to see again this siloing of the work on early childhood development and obesity and health promotion and obesity prevention. We're starting again to fall into these silos where we're either working on obesity prevention or we're working on child development. I, as a pediatrician, think that they are completely intertwined, and one shouldn't mean that focusing on obesity prevention shouldn't mean that we don't take the opportunity to also work on healthy child development when we have this opportunity in this critical period of life. And so one of the interventions that we are doing with some support from the Boston Foundation in community health centers in the Boston area is really to start developing collective impact activities to change our systems where children and their mothers and these vulnerable families interface with all of these different settings that already exist: OBGYN, pediatrics, WIC, fatherhood programs, early intervention, early care and education, work sites, home visiting programs, to change those systems, not just to look at the outcomes that I study and that many of us study in our research, which is childhood obesity, but to really start thinking creatively about how do we merge the work that we are doing around childhood obesity prevention to also think about screening for adverse childhood experiences, screening for maternal depression, which can also impact obesity, but can also really have an effect on social, emotional, and physical development. I'll end there, again, with a very quick summary that childhood obesity interventions may produce the largest magnitude of effect if they're begun in the earliest stages of life. Unfortunately, we have very few effective interventions during the pregnancy to age 2 period, and those that have been successful only, or some have had short-term effects and not sustained effects in long-term studies, and really thinking creatively about novel interventions that operate at a systems level rather than at the individual level. Thank you.